Very good afternoon, dear friends. Today we're going to discuss about one important morbidity which leads to significant mortality and neurological morbidity in preterm newborns, necrotizing enterocolitis. Although the incidence of NEC has been steadily declining with evolutions in neonatal intensive care, the incidence currently remains at 1 to 5% of all admissions and affects 10 to 15% of preterm very low birth weight neonates. This is a condition. The condition is associated with significant case fatality rate with 20 to 40% mortality and up to 50% of extremely low birth weight neonates need surgery secondary to necrotizing enterocolitis. Not only does it cause significant increase in mortality and morbidities, but it is also associated with long-term neurodevelopmental impairment and increased cost of healthcare, with some of the babies going into malabsorption secondary to short bowel syndrome. NEC, especially NEC more than stage 2, is associated with devastating inflammation of the bowel, and mortality and morbidity is particularly higher among extremely preterm neonates. The incidence of necrotizing enterocolitis in extremely preterm neonates has not changed significantly despite advances in neonatal intensive care. It continues to have association with significant mortality as well as morbidity, particularly in newborns less than 28 weeks of gestational age. NEC is not only associated with clinical complications, including mortality, morbidity, short bowel syndrome, subsequent stricture, but can significantly increase the duration of hospitalization and hence the cost associated with healthcare. It has been seen that medically manageable newborns with necrotizing enterocolitis are hospitalized for 60 days longer when compared to unaffected controls. Whereas for surgically managed NEC, and if neonates did not require surgery for NEC, the average duration of hospitalization was longer by 22 days. The total estimated cost of caring for necrotizing enterocolitis is an additional health cost burden of $500 million to $1 billion every year only in United States of America. Short bowel syndrome, which is one of the common severe complications of NEC, also increases the cost of care significantly. So having understood the epidemiology and the additional healthcare burden that is created because of necrotizing enterocolitis, let us discuss something about the etiology and pathophysiology of NEC. NEC is caused by a combination of multiple factors, which can be easily remembered with the letter I: intestinal immaturity, imbalance of microvascular tone or ischemia, intestinal colonization by pathogenic microbes, which is also called as dysbiosis, and abnormal immunoreactivity. All these factors on the background of enteral feeding with genetic susceptibility may predispose to NEC. So it has been seen that in neonates who are destined to develop necrotizing enterocolitis, the gut microbiota is characterized by lesser diversity, which means that there is a more narrower spectrum of microbes that are isolated from these organisms. There is also a genetic predisposition, particularly in the form of polymorphisms of toll-like receptors, which is the important receptor that is associated with the cascading of the second messengers that leads to inflammation culminating in NEC. And NEC is also characterized by an alteration in the gastric pH, where acid inhibition and increase in the pH of the gastric lumen to an alkaline pH may make the newborn more vulnerable to exaggerated inflammation, tissue injury that can eventually culminate in necrotizing enterocolitis. Immature intestinal barrier can be heightened by decrease in mucin production, decrease in the production of secretory immunoglobulin A, all these factors leading to lower intercellular junction integrity and increased permeability. So it has been seen that in premature infants, the disruption of the normal patterned microbiome progression, which can be predisposed by empirical usage of broad spectrum antibiotics and abnormalities in the feeding pattern, for example, increase in the proportion of formula feeding, can lead to microbial dysbiosis. Now, dysbiosis is a term which refers to the alteration of the normally seen commensal microbacteria like lactobacillus or bifidobacterium, which get replaced by an abundance of proteobacteria and decrease in the abundance of firmicutes. These factors in the presence of genetic predisposition, particularly polymorphisms in the toll-like receptors, which lead to abnormal immune response, leads to the proliferation of pathogenic microbacteria, which leads to the release of lipopolysaccharides, which is one of the important antigens released by gram-negative bacteria, leading to further activation of the toll-like receptor for receptor activation and the downstream production of inflammatory markers such as chemokines, cytokines, and activation of neutrophils. All these factors eventually resulting in exaggerated inflammation. Side by side, newborns with altered microvascular response, characterized by abnormalities in the presence in the production of VEGF, which is vascular endothelial growth factor, leading to abnormality in the microvascular tone of the gastrointestinal system and alteration on the intestinal metabolome, where there is decrease in production of short-chain fatty acids such as butyrate and propionate, also contribute eventually to increase in the intestinal permeability, increased translocation of fluids, tissue injury, and necrosis, eventually resulting in necrotizing neonatal enterocolitis. On the right side, you can see the flow chart, which relates the abnormal microbial dysbiosis in the gut, which is linked with subsequent brain development with respect to memory, risk-taking, exploratory behavior, and synaptogenesis. So NEC is not just a condition that is characterized by intestinal inflammation, but can also have ramifications in the subsequent neurodevelopmental impact of newborn babies. When we talk about the pathogenesis of NEC, an important role is played by toll-like receptors. TLR4 in particular mediates the lymphocyte influx, which induces neonatal NEC, and breast milk particularly is protective against NEC by inhibiting TLR4 activation in the intestinal epithelium by activating epidermal growth factor receptor. We have been frequently hearing this term microbial dysbiosis as an important factor predisposing to NEC. This term essentially refers to an alteration in the normal gastrointestinal microbial flora, where in newborns who develop necrotizing enterocolitis, we see a relative abundance of gamma proteobacteria, which essentially refer to the gram-negative bacilli such as E. coli or Klebsiella, and relative paucity of strict anaerobic bacteria, especially firmicutes and negativicutes. And these changes by many days may precede the onset of necrotizing enterocolitis. So disrupted gut microbiota or dysbiosis, which is mainly due to organ immaturity, which can also be due to the use of broad spectrum antibiotics during hospital stay, and hospital-based microbial environment, and abnormal pattern or mode of feeding, for example, predominance of formula feeding, play a key role in the pathogenesis of NEC. The clinical staging of NEC has been described by modified Bell's staging, which has been given by Kligman and Walsh. So NEC is essentially divided into 3 stages based on the clinical parameters, as well as associated radiographic abnormalities and local gastrointestinal findings. Stage 1, Stage 2, and Stage 3. Stage 1 or suspect NEC is characterized by non-specific clinical findings like the baby developing apneas or repeated episodes of cessation of breathing, bradycardia or tachycardia, and temperature instability. Now, these may not be specific only to NEC. This can be seen in any sick preterm newborn. The associated radiographic findings are also fairly non-specific in stage 1 NEC, characterized by either normal gas pattern or presence of mild dilatation of the bowel gas, characterized by ileus. Specific gastrointestinal findings may include the presence of mild abdominal distension associated with occult blood positivity in stool and gastric residuals or abnormal aspirates. Stage 2 NEC, which is also called definite NEC, again can be categorized into 2A and 2B. In both these stages, the baby continues to have clinical manifestations as we saw in stage 1, such as apnea, bradycardia, and temperature instability. In stage 2B, newborns may have a lab triad of NEC, which includes 3 abnormalities: persistent metabolic acidosis, thrombocytopenia, and persistent hyponatremia. So these 3 abnormalities, metabolic acidosis, hyponatremia, and thrombocytopenia, are often referred to as the metabolic triad of NEC. And this is something that is prominent in stage 2B in terms of clinical findings. When we look at the radiological findings in stage 2, in stage 2A, we see the characteristic finding of pneumatosis intestinalis, which is the presence of intramural gas. So normally we are supposed to see gas in the bowel wall intraluminally, that is within the lumen. But if you start seeing gas within the bowel wall or intramural gas, then this is called as pneumatosis intestinalis. This is a very characteristic finding that is seen starting from stage 2A of NEC, and it can be seen in the more severe stages as well. In stage 2B, we also see an additional finding radiologically, which is called portal venous gas or pneumobilia. So we'll be seeing some characteristic X-rays. Now, pneumobilia refers to the presence of gas within the portal vein. So you'll be able to see a tree-like branching pattern of gas within the liver shadow. Some infants can also start exhibiting ascites in stage 2B. When we look at the gastrointestinal findings, we may see in stage 2, there is more significant abdomen distension, presence or absence of tenderness can be there. The abdomen might feel tense on palpation. The infants may also start developing fresh blood in stool, which is an ominous sign, hematochezia, which refers to the presence of ongoing intestinal necrosis or gangrene. In stage 2B, when compared to 2A, newborns can have more severe abdomen tenderness and there can be abdominal wall edema. So when you palpate the abdomen, you may see some degree of pitting in stage 2B. Stage 3, which is the more advanced stage of NEC, is again divided into stage 3A and 3B. In 3A, the clinical findings are the newborn is more sick now with presence of bleeding due to DIC, coagulopathy, hypotensive shock, multi-organ failure in the form of oliguria, indicating acute renal failure. There could be mixed acidosis, both respiratory and metabolic acidosis. In stage 3B, the baby can have more significant worsening of the vital signs. There can be significant hypotension, tachy or bradycardia. There can be significant temperature instability, and the newborn is in florid multi-organ failure. Radiologically, 3A is characterized by ascites. So the most important finding in the X-ray is you may have been seeing so far dilated bowel loops, pneumatosis, and pneumobilia, and suddenly you start seeing that there is paucity of gas within the bowel, and there is pushing displacement of the bowel gas loops towards the center of the abdomen, and these findings indicate the presence of ascites. At this stage, note that there is not yet presence of free air that is noted in the peritoneum. Now, free air or air under the diaphragm is a characteristic sign of stage 3B of NEC, which indicates the presence of pneumoperitoneum or perforated bowel wall. So in 3A, there is only transmural necrosis of the bowel wall, which leads to ascites because of transuration of fluid, but there is not yet the presence of perforation. Perforation has occurred in stage 3B. So in both stage 3A and 3B, one would consider that this baby is heading towards surgery. In terms of GI findings, there would be significant abdominal wall erythema, induration, and there could be bluish discolorization of the abdomen wall that could be seen with stage 3 NEC. So these are some characteristic clinical pictures. So one can appreciate that this newborn with possibly with definite necrotizing enterocolitis has significant distension of the abdomen wall. On closer examination, you can also appreciate that there is erythema around the umbilicus. Other findings, like the presence of tense abdomen or absent bowel sounds, can only be ascertained with palpation and auscultation. This is a gross kind of picture taken during intraoperatively, and you can see that there are small specks of air that can be seen within the blood vessels. So this in more advanced stage can track down to the intestine, and then you can start seeing pneumatosis intestinalis. This is another picture which is showing frankly necrosed bowel. We can see absolute absence of vascularity. The bowel wall has been completely discolored. It is almost looking pale brown in color. This indicates the presence of frank necrosis, and this is a very ominous sign. This might mean that we have lost already a significant segment of the intestine, and these newborns, even when they survive, can end up with short bowel syndrome. So we'll see some characteristic X-rays. So we'll begin by a normal looking bubble gas pattern, which you can appreciate on the left side of the screen. So you can see this is a baby with a normal looking bubble gas pattern. So most of the times by around 6 to 8 hours of age, gas has already reached the lower intestine. And by around 18 hours, most newborns will start to have appearance of gas in the pelvis. The figure on the right shows intramural gas or pneumatosis intestinalis. So this again can be present predominantly in the subserosal or in the submucosal level. When intramural gas predominantly populates the submucosal part of the bowel wall, we start to see something called a soap bubble appearance, which you can see here. So you can see small specks of gas against the opaque background of the bubble here. So this is characteristically called as soap bubble appearance and refers to the presence of intramural gas. So we see another picture of soap bubble appearance now in the center. So when you start seeing these small specks of gas, so this is not typically the appearance of intraluminal gas, which is more well demarcated. So these small specks of gas refer or signify the presence of gas within the bowel wall or intramural air. And this is what we refer to as pneumatosis intestinalis. Now, when gas is present predominantly in the subserosal layer, we may start seeing the intramural gas appearing as a linear streak, as you can see here. This is also called as tram track appearance. So you can see multiple streaks of air that are lining the bowel, which refers to air that is present within the bowel wall here. So one of them is indicated by the white arrow. But this is seen more extensively in this X-ray. So this is also a picture showing pneumatosis intestinalis. This is again an image where you can see on careful examination, there is intramural gas, linear streaks of gas that is seen both in the right lumbar region. It is also seen in the left lumbar region. We also see in the left iliac fossa a typical soap bubble kind of appearance, which refers to the presence of intramural gas, predominantly in the submucosal layer. Another X-ray here showing not only the presence of extensive intramural air, you can see both a combination of soap bubble appearance as well as linear streaks of intramural gas. But you can see the arrow mark 1 referring to the presence of pneumobilia or portal venous gas. So there is air that is branching within the density of the liver. So whenever you see a newborn with definite NEC, do look for this sign because this can easily be missed. And unless we are careful to look for the presence of portal venous gas, this may be missed on the abdomen radiograph. Of course, an ultrasound abdomen is much more sensitive to pick up pneumobilia when compared to abdomen X-ray. So when you see portal venous gas, the staging of NEC automatically becomes stage 2B. So it has been said that only around 30% of the times when the baby has pneumobilia, the abdomen X-ray can pick it up. So up to 70% of the times, the abdomen X-ray is quite insensitive to pick up pneumobilia. So then you may have to ask for an ultrasound abdomen, which is more sensitive than abdomen X-ray for picking up pneumobilia. Now, in more advanced NEC, we start seeing this sign, which is called as American football sign. So what does this mean? If you can carefully appreciate, there is a white line that is traversing between the superior surface of the liver. It is starting from just below the diaphragm. This is the line marked by the arrow mark number 1. And this is going down, tracking down right until the umbilicus. So very often we may think that this baby has an umbilical venous catheter. So there is a line density that is connecting the inferior surface of the diaphragm, traversing across the liver and coming down until the umbilicus. I hope you are able to see it. This is a prominent falciform ligament that stands out when the baby has pneumoperitoneum. So in early pneumoperitoneum, free air outlines both surfaces of the falciform ligament, making it stand out. So, and this is the atretic part of one of the umbilical veins that was previously present in fetal life. And we all know this is how the falciform ligament was formed. This ligament is normally not seen in an abdomen X-ray, but it is seen when both sides of the falciform ligament are surrounded by air, which makes it look prominent. So this is one of the important signs on an AP film that helps us to suspect that there is pneumoperitoneum. Of course, when you want to confirm the presence of pneumoperitoneum, it is better to go for an erect X-ray abdomen, where, as you can see here, the arrow mark number 1 is showing free air just above the liver surface in the suprahepatic surface and just below the diaphragm. You can appreciate that there is free air. So this is air under the diaphragm. That's one of the characteristic signs of established pneumoperitoneum. We can also see air on the inferior margin of liver, which is highlighted here with the arrow mark 2. And then the third sign here, which is a Riegler sign, indicates that the bowel wall can be outmarked like a pencil lining whenever there is free air in the peritoneum because of the presence of air both on the inside as well as on the outside of the bowel wall. So normally, we all know that air is only present within the lumen of the bowel. But if you were to have air both intraluminally as well as extraluminally, as when it happens with perforation, the bowel wall or the bowel wall layer can stand out very prominently, and this is called as a Riegler sign. So air into the diaphragm, triangular presence of air in the inferior hepatic surface, and Riegler sign, these are all signs of advanced NEC or presence of pneumoperitoneum. This is a lateral radiograph taken in the same clinical situation. Again, it indicates the presence of free air outlining the surface of the liver, indicated by the arrow mark 3. We can also see the presence of extensive pneumatosis intestinalis. Now, in NEC, there are some other important signs also that can be seen, which include the following. Whenever we see persistent fixed bowel loop, it indicates the presence of gangrenous bowel. And this may also be a very ominous sign. So if in repeated X-ray images over 48 hours, you start seeing a persistent fixed bowel loop, it may indicate the presence of gangrene, and this is one of the relative indications for surgery. Likewise, persistent pneumatosis intestinalis, which is non-resolving over more than 48 hours, may also be an ominous sign. It might indicate the presence of extensive necrosis, which may eventually evolve into gangrene, and one may have to keep the pediatric surgeon in loop. Bowel wall thickening, which is often described in NEC, is a term given when the thickness of the bowel wall exceeds the thickness of the corresponding intervertebral disc. So whenever you see a bowel wall, compare it with the thickness of the corresponding intervertebral disc. And if it is exceeding the thickness of the corresponding intervertebral disc, you say that bowel wall is thickened. This is one of the signs in the earlier stages of NEC, like stage 1. But note that bowel wall thickening doesn't happen actually, but it rather refers to the presence of interbowel fluid, which is a sign in early stages of NEC, and hence bowel wall thickening is actually a misnomer. So you can see this in this particular X-ray, where the area of the bowel wall highlighted by the white arrow is practically thickened. Its thickness is exceeding the width of the corresponding intervertebral disc space. So whenever we are suspecting or dealing with NEC, a single radiograph is obviously not going to be enough. You may see pneumatosis intestinalis on one film, like you see on this particular film, but it is the serial follow-up images taken usually at a gap of 12 to 24 hours based on the clinical severity of sickness that really helps. So the maximum probability of the newborn progressing to perforation is generally within the first 24 to 48 hours from the diagnosis of NEC. So during this phase, one may have to be additionally careful. You may want to repeat X-rays a little bit more often because sometimes clinical examination can be quite deceptive. So it is the serial radiographs and the information that we get from serial follow-up that is more important. Like in this particular film, you can see that on serial radiographs, probably the extent of necrotizing enterocolitis, the extent of pneumatosis intestinalis is fairly static, but you may begin to worry if you start seeing a fixed bowel loop, which you can appreciate in the right iliac fossa. So if you start seeing persistent fixed loop of bowel over 24 to 48 hours, it may indicate the presence of ongoing gangrenous gas. Likewise, in a newborn with NEC, if one starts seeing that there is resolution of intramural gas or pneumatosis intestinalis with paucity of gas setting in, again, this may indicate the presence of intestinal ischemia, and this also could be an ominous sign. Now, while discussing about necrotizing enterocolitis, it's also important to remember that not every condition that presents with abdomen distension or vomiting is NEC in a preterm baby. So there are NEC mimics, and we are going to discuss some of them with some case examples. So you're dealing with a 27-weeker, 1100 grams antenatal steroid-covered baby who received surfactant at 1 hour of life and was subsequently managed with CPAP. There was no evidence of hemodynamically significant PDA. The newborn is begun on 30 ml per kg per day of feeds, has also been started on early hydrocortisone, possibly as per the unit policy there. And on day 4, the baby developed sudden onset abdominal distension. Respiratory and hemodynamic status continues to remain stable. And this is the abdomen X-ray taken after deterioration. You can see that there is extensive free air that can be seen in this X-ray. There is free air lining the superior and the lateral margin of the liver. Air under the diaphragm can be appreciated on both sides, right and left. And this is classical perforation secondary to spontaneous intestinal perforation. So what differentiates SIP versus NEC? SIP, which is characterized by a relatively normal and healthy bowel and no preceding evidence of other signs of NEC like vomiting, aspirates, abdominal distension, or radiological signs like pneumatosis, usually affects preterm infants who are on a combination of drugs like steroid, hydrocortisone with non-steroidal anti-inflammatory drugs like Brufen. It is usually an early onset phenomenon, normally seen within the end of the first week. And in contrast, NEC is generally seen after enteral feeding has been well established, usually into the second week of life. And it may be preceded by other clinical and radiological signs of necrotizing enterocolitis, such as vomiting, abdomen distension, presence of abdominal wall erythema, edema, tenderness, etc. NEC is usually something that involves the ileocecal area, but it may sometimes be more extensive. In contrast, spontaneous intestinal perforation usually involves a single perforation in the terminal ileum. The differentiation can sometimes be very tricky. The treatment remains the same. It is in the form of, if it has progressed to perforation, then the baby would require laparotomy and either resection anastomosis or a stoma, depending upon the extent of the disease. The second condition, which often mimics NEC, is this: a 30-weeker SGA baby, 800 grams, smaller for gestational age, with mild asphyxia, is born with maternal abnormal umbilical arterial flows in the form of reversed end diastolic flow, is initially on CPAP. At 24 hours, the baby is still not yet started on enteral feeding. There is mild abdomen distension, although the abdomen is soft on palpation. The baby has not passed stools and bubble sounds are not heard. And when you get an abdomen X-ray, it usually shows dilated bubble loops. This is characterized by a condition called intestinal ischemic necrosis, commonly seen in preterm infants with abnormal umbilical arterial Doppler flows. Although this is usually seen with preterm infants delivered following Doppler abnormalities, this may also be seen with term infants who have cyanotic congenital heart diseases like truncus arteriosus, hypoplastic left heart syndrome, polycythemia, or birth asphyxia. The third condition that may often cause confusion is this. Let's discuss this with a case example. This is a late preterm, 37 weeks, 2.7 kg, appropriate for gestational age male newborn, delivered by normal vaginal delivery. Initially managed for mild respiratory distress with oxygen, was established on full feeds from birth, initially with term formula and later on mixed feeding, term formula and breastfeeds. On day 9, the baby develops abdomen distension, blood in stools, and emesis. The abdomen is essentially soft on palpation, and abdomen X-ray does not show any specific finding indicative of NEC. There is only non-specific bubble loop dilatation. You don't see other signs like pneumatosis intestinalis or pneumobilia, etc. The baby is kept NPO for a couple of days and then restarted on feeding. And the same thing repeats again and again on day 21, day 29, and day 45. So repeated episodes of NEC-like illness in an apparently full-term mature baby who doesn't apparently have any risk factors for necrotizing enterocolitis. Now, what could this be? The presence of some important differentiating signs like the onset of gastric residuals with blood in stools in a baby with absolutely no risk factors for NEC, or no tenseness or tenderness on abdomen palpation could indicate the presence of what we know as FPIES, food protein induced enterocolitis syndrome. In contrast to necrotizing enterocolitis, this condition frequently recurs with re-establishment of feeding and may settle only with the change in the nature of feeding, wherein we may have to either use mother's milk when mothers are advised to withhold dairy products, or extensively hydrolyzed formula in case one has to use supplemental feeding. In this condition, newborns tend to have less neutropenia and thrombocytopenia and rather would have more eosinophilia and leukocytosis, as can be illustrated in some of these case examples. So one has to remember these NEC mimics, which are clinical mimickers of NEC, whenever we are dealing with newborns who may have signs of doubtful necrotizing enterocolitis. It is important to differentiate what is NEC and what is not to help us decide the further management. Let us now discuss about the prevention and management of NEC. The first and most important strategy to prevent NEC is to use human milk wherever possible. Mother's own milk is strongly recommended for feeding the low birth weight infant. And if mother's own milk is not available, the next best option would be to use pasteurized donor human milk from a human milk bank, so that the risk of viral transmission would be kept to the least possible extent. And this is only applicable to settings with facilities to provide pasteurized human donor milk and with appropriate growth monitoring and possibly fortification. When human milk or donor human milk are both unavailable, then only then formula milk is to be considered because it is obviously associated with higher risk of necrotizing enterocolitis. Now, along with the use of human milk alone, it has also been seen that the use of an exclusively human milk diet, which means fortification of human milk also done using a human milk-based fortifier, has been associated with much lesser risk of necrotizing colitis, enterocolitis, as can be seen in this particular randomized controlled trial that compared human milk-based human milk fortifiers versus bovine milk-based human milk fortifiers. And it was found newborns who were fed on an exclusively human milk diet, which included human milk fortified with a human milk-based HMF, were associated with much lower risk of NEC. It is also important to remember that the use of a standardized feeding policy, wherein the guiding rules for initiation, for escalation of enteral feeding, and for the time to reach full enteral feeding, as well as fortification, when these are all clearly laid down for the unit, the risk of necrotizing enterocolitis is reduced by as high as 78%. So what this means is there must be uniformity on how much milk to start, when to start, what milk to start, how to escalate, when to stop feeding, if at all feeding has to be stopped for feeding intolerance, and how early one should target to reach full feeding. Last but not the least, the use of probiotics, which are sources of either live microorganisms or spores, which when provided to the host can confer favorable health benefits, has been found to result in a significant reduction of severe NEC, all-cause mortality in preterm neonates, as well as late onset sepsis. This has been demonstrated in a conclusive systematic review that included more than 30 randomized controlled trials. Multiple mechanisms have been proposed for the favorable actions of probiotics, including the maintenance of mucosal intestinal barrier integrity, regulation of bacterial colonization, and activation of intestinal immune defense mechanisms, and a modulation of hyper-exaggerated intestinal inflammation. The use of probiotics has not only found to be useful in high-income countries, but has also been found to be useful to reduce the incidence of NEC in low-middle-income nations like ours, where their use has been associated with a 64% reduction in NEC and a significant reduction in other outcomes like sepsis, mortality, and an earlier time to reach full feeds and time to discharge. Multiple bodies have come up with recommendations on the use of probiotics. It appears that a combination of multiple strains may be better than using a single strain probiotic. And when you use a combination, it must have a mix of at least one or more species of bifidobacteria and lactobacilli. If a single organism probiotic is administered, then bifidobacteria seems to be more effective than lactobacilli, and both are more effective than Saccharomyces. So overall, try to use a combination of multiple strains containing at least one strain of bifidobacterium and lactobacillus. If the single strain probiotic has to be administered, then go for bifidobacteria-based probiotics. Among bifidobacteria, Bifidobacterium infantis seems to have advantages in early colonization of the gastrointestinal tract, and Lactobacillus acidophilus may have advantages over other species of Lactobacillus. So we in KIMS Cuddles NICU follow this protocol for the use of probiotics. Of course, the use of or the policy for probiotic can be individual unit dependent. We use probiotics for all neonates born with birth weights below 1,250 grams or neonates between 1,250 and 1,500 grams with abnormal Dopplers. The dose that is to be used is 0.5 sachets used twice daily until a feeding volume of 5 ml and 1 sachet twice daily beyond 5 ml of feeding per session. Probiotics are to be started when the baby tolerates at least 20 ml per kg of enteral feeding and continued until 34 weeks of post-conceptional age or discharge, whichever is earlier. Now, prebiotics are neutral combinations of short-chain galacto-oligosaccharides or long-chain fructo-oligosaccharides have also been studied for the purpose of reduction in necrotizing enterocolitis. Although they have not been found to be useful for reduction in NEC, the use of prebiotics is also associated with significant lowering of neonatal sepsis and all-cause mortality and has been found to have some advantages in establishing full feeds faster by at least 1 day. Now, the use of symbiotics is also becoming a popular concept, which is a combination of both prebiotics and probiotics. Prebiotics are non-digestible carbohydrates, which when given to the human host, will allow or will promote the growth of useful commensal organisms such as lactobacilli. Whereas in probiotics, we directly supply these organisms. So we have discussed some things about the prevention of NEC. Now let's discuss about management of established NEC. So once the baby presents to us with signs of NEC, we try to categorize this based on the Bell staging 1, 2, or 3. In stage 1, which is suspect NEC, usually the baby is kept nil per oral for 48 to 72 hours with continuous gastrointestinal decompression by inserting a feeding tube. Low contrast suction can be used. Low constant suction can be used, and making sure that we replace the gastric residuals with appropriate concentration of fluids containing sodium and potassium chloride, etc. One may also need to evaluate the baby for thrombocytopenia and leukopenia by performing complete blood counts and look for C-reactive protein levels, serum electrolyte levels, manage any abnormalities like hyponatremia or hyperkalemia. The baby will need to be monitored both clinically and with serial abdomen radiographs based on the clinical indication. Most of us would begin antibiotics in this stage of NEC because this also may be non-specific for some of the signs can be confused with sepsis. In NEC stage 2, one may have to use serial abdomen radiographs to decide whether the baby is progressing. Most of these babies will need to be kept NPO for at least 5 to 7 days or maximum of 10 days if it is NEC 2B. And they obviously would also become candidates for parenteral nutrition because of the prolonged duration of fasting. During this phase, the babies would have to be constantly monitored for clinical deterioration with vital signs being closely watched for and lab markers in the form of electrolytes, serial blood counts 12 to 24 hourly for any deterioration in form of neutropenia, thrombocytopenia, hyponatremia. In NEC stage 3 or advanced NEC, the baby again will have to be managed on similar lines as we discussed earlier. The difference would be that the duration of NPO may be longer. It may take as long as 10 to 14 days, especially if the baby required surgery in the form of laparotomy. The baby will need to be seen by a pediatric surgeon when the baby progresses into stage 3 because we know that there is a high risk of evolution into pneumoperitoneum, which may involve the pediatric surgeon. The role of a glove drain versus a laparotomy has been studied and debated extensively. When the baby is hemodynamically unstable, we may be able to buy some time by putting in a flank drain or a peritoneal drain. This may be very useful in a hemodynamically unstable baby with necrotizing enterocolitis, but eventually all babies who had a flank drain will eventually need laparotomy. The indications for surgery in NEC would include the presence of intestinal perforation per se, as indicated by pneumoperitoneum, or other signs, relative signs like the presence of a fixed adynamic loop, which indicates a necrotic bowel loop, signs of necrotic bowel loop clinically in the form of persistent severe thrombocytopenia, severe metabolic acidosis, or where you persistently seen signs of pneumatosis intestinalis, which are non-resolving. To summarize, NEC is a significantly morbid condition that affects around 5 to 10% of preterm very low birth weight neonates. It is associated with 20 to 25% mortality, with significantly higher mortality and morbidity in extremely preterm infants. Although overall incidence of NEC has been coming down, the incidence of NEC still remains significantly high among extremely preterm infants. The gold standard for diagnosis is an abdomen X-ray, but you may need to get an ultrasound abdomen in some specific clinical dilemmas, such as doubtful NEC stage 2B. While NEC is a very common and a potentially fatal condition, we also must be sure that we are not confusing some of the NEC mimics for the same, which includes spontaneous intestinal perforation, ischemic colitis, which can be seen in babies with GI ischemia in the form of Doppler abnormalities, food protein related enterocolitis syndrome, and surgical conditions which can present with an obstructed bowel. It is always better to prevent NAC than manage it, and prevention is possible with the most effective strategy being the use of an exclusive human milk-based diet. Thank you all for your patient listening. And if you have any questions or queries, please make sure that you drop a comment in the comment box. Thank you. If there are no questions, we'll thank you all for attending and see you back next Friday with another interesting topic. Thank you.